Hi, everybody. It's Carol from the STS. We're going to get started here with our monthly webinar for November. On the line with me from STS, I have Leanne Jones, Addie Dolan, Catherine Holyfield, Sydney Clinton, Emily Conrad, and the famous Melinda Offer. And from the IQVIA side, we have Melanie, Joe, and Jean, and Steve. So thanks, everybody, for joining. Hope you enjoyed that music. That was JJ Mofro and Gray, Brighter Days. Okay, so today's the monthly webinar for adult cardiac, and it's November 3rd. I've already done the welcome and introductions. A couple STS important dates, STS updates, IQVIA update, and then Melinda has AQO edition, STS education. Be sure to enter all your questions into the Q&A box, and we'll be getting to them. We have quite a list of questions to go through that were left over from AQO. So if we don't get to your questions today on that come through today for this webinar, we'll do our best to get to them on the user group call later this month. Important. So I'm going to kind of go through these quickly, just a quick update from IQVIA so we can spend time on the questions. Important dates for adult cardiac. Today is the monthly webinar. November 17th is our user group call. December 1st, next webinar. December 15th, user group call. December 7th, the harvest closes for harvest 4. That's OR dates through 9/30/2021. And that was moved. We moved that date last week from November 12th through to December 17th. Because we're waiting for that data to be populated from harvest 3. I'll get to that in just a second. And then the December 21st is the opt-out ends for harvest 4. The harvest dates for 2022 have been posted on the STS website. All of these are 8 weeks from the last date 8 weeks from the last date included in the reporting period, except for the harvest 4. I think this is 7 weeks because 8 weeks would be Thanksgiving. So keep an eye out, make sure you mark these on your calendar. And again, they're posted on the website. I'm really excited. Melinda just messaged me and says she's seeing Mofo and JJ Gray next weekend in Missoula. I wish I was there with you, Melinda. Okay. STS updates, the AQO was available in the STS Learning Center. You can still access it from the platform where you logged in to join AQO. If you didn't get a chance to watch all of the presentations or you want to go back and watch something, they are available, and I'll show you how to get there. Harvest 3 data is back from analysis from DCRI. IQVIA is preparing for the release. It's going to take a few weeks, so we're hoping that we have harvest 3 data back and populated and available for sites prior to the harvest 4 close date. And then the November training manual is posted. All right, and now I'm going to hand it to Joe for a quick IQVIA update. Joe Brower.
Thank you, Carol Crone. Good afternoon, everybody. Just like Carol said, a few updates. We did put a release through over the weekend on October 30th. So I just wanted to run down some items that were included in that release so that you are aware that these have been fixed. Starting with the participant non-analyzed dashboard report, SCS 7193. The total postoperative ventilation hours was displaying as missing when extubated in OR was answered NA, which should not have been happening. And so that has been fixed. And then STS 7152, the dashboard was not displaying the counts for patients marked as expired in OR within the MTOPD plus died in hospital plus died in OR line on that report. So that should now be functioning properly. SCS on the missing variable report, SCS 7045, the MVR was displaying various anesthesia variables as missing.
Did I lose Joe's volume?
Yeah, I don't hear him, Carol.
Okay, Joe, I think we lost you.
Joe.
Melanie, did you want to go ahead and take
I can just take it on over. I don't know what happened to Joe. Hold on one second. Let me just fix my screen here so I can see. All righty. Okay, so we were at 7152, the dashboard, or we
We're
at
at
missing
70.
variable?
Yeah, we're at
Missing
70.
variable.
Yes,
There we go.
ma'am.
All right. So for the missing variable report, we have the MVR was displaying the diet and OR intra-op post procedure TEE as missing, and it was displaying when the organization participates in adult anesthesia was set to no. That should not have been occurring, so that has also been resolved. Then we have 7194. The MVR was not displaying the surgical site infection when that was missing. So in those instances, when the item was left blank, it was not being flagged on the MVR. That has been updated and now will be presented on that report. And then we have the risk adjusted updates. This is for the analyzed reports. We have 6785, the NQF outcomes measure, the items in the STS aggregate section for, I believe, the 10th, 50th, 90th, going off the top of my head, was displaying with a percent sign, and that should have been displayed as a ratio. So the percent has been removed and you will be able to see those results as expected. Then we have 7236, the rating trends report was displaying out of order when you exported the results for that. That has been updated, so you should see the correct years showing in the correct order when exported from the dashboard. And then the last item is 7335. Users were getting an error message when trying to print or export the PDF results. It was displaying page not found. That also has been resolved. And I believe that should be it in regards to the items that were deployed on the 30th.
That's it, Melanie. There's nothing else here. I have a question on the participant dashboard and the missing variable report. Do sites need to re-upload their data to see these changes take effect?
Great question. And no, they do not. The calculations will automatically be applied on the data set that is already within the database. So the report will basically refresh. So when you rerun that report, it will update accordingly.
Wonderful. Thank you.
You're welcome.
Any known issues? IQVIA will post them to the platform. And if you're submitting a ticket that's already under review, please make sure you include your previous ticket number with that. And I think that's it. All right, Melinda, I'm handing it over to you. Are you there? And I'll connect it, okay?
Yes, I'm here. I had a tooth pulled yesterday, so my voice is a little weird, but I think we can work through this.
Okay, if you need to hand it over to me, just let me know.
All right, should I share my screen or are you just gonna do the slides for me? How's that?
I can click them, yeah.
Okay, all right. So, hey everybody, this is the questions that were left over from the data manager session at AQO. And so I put together a little slideshow just to try to answer everybody's questions. So the first one has to do with sequence 405, chronic lung disease. What if our pulmonologist classifies our patient as mild to severe obstructive or restrictive? Do I use the pulmonologist or with the manual? And the answer is you need to code the severity based on the criteria in the training manual, not MD documentation. And I wasn't quite sure really about this question if you were talking about the type of lung disease or the severity. So if you were talking about the type, then it looks like you've got some clarification that needs to be done because it talks about severe, obstructive, or restrictive. So I answered this for severity, but I really didn't know if that was the intent of the question or not.
Didn't hit all the clicks.
Yes, code. I thought there was another answer there. So when you're coding the severity, you're going to code the most severe category if you have a difference between the FEV1 the DLCO, the ABG, and the inhaler criteria. So we want to take the most severe category because this is in the risk model. And we can go to the next slide. Okay, this again, it has to do with chronic lung disease. If a CTA states emphysema and it is not documented anywhere else, can we choose severity unknown? And in this scenario, you do have documentation of emphysema. So you know the patient has lung disease, but you really don't have any criteria to determine the severity. So you'd have to code it as chronic lung disease severity unknown in this situation, because there's no criteria to determine how the severity. Okay, next question. Chronic lung disease again. Does the use of as needed inhaler account for the use of inhaler for the severity classification? And the answer to that question is yes. If you are using chronic PRN inhalers that are used to treat your lung disease, then of course you can use that in the criteria for a classification. Oh, one more chronic lung disease one. This has to do, it says, with COVID resources in-house and surgeon office is stretched. Head of pulmonary wants to stop spirometry. What do you recommend? Well, it's Carol's fingers are slow. It's important that your hospital's leadership know the severity of chronic lung disease is a variable in the risk model. So, I mean, we certainly can't say, you know, you should automatically be doing this, but just know that if you do it, it is part of the risk model. And that may be something that you could talk to the head of pulmonary about and your surgeon. And that might influence their decision. Okay, another chronic lung disease one. With someone who is an acute heart failure and has a pre-op PFT, their value seems to be falsely low. Should we still be using the PFT, or in those cases, should they be ignored? And the answer is you can use the PFT results unless you have some documentation in the medical record that the test was invalid. I mean, you know, heart failure does affect lung function, and it most commonly would probably affect that PFT. So if there's no documentation that it's not an invalid test, then you should be able to use it. Okay, the next question. We're going on to heart failure now, which is sequence time 15. Can the NYHA class be documented by an advanced practitioner, such as a PA or NP? And yes, provider documentation is acceptable. So that would include nurse practitioners, PAs. And you know that for this field, it does have to be clearly documented by a provider, whether it be a physician or an advanced practitioner. We can't infer the NYHA class based on the patient's symptoms in the STS database. And the next question also has to do with NYHA class. Is it okay to consider and code the NYHA class if it is only documented by anesthesiologists in the anesthesia record? Well, it depends. Depends on when the anesthesia documentation occurred, because the NYHA class has to be documented within 2 weeks prior to OR entry. So if this was a pre-anesthesia document prior to the patient going to the OR, then yes, you could use that. But if it's actually the actual anesthesia record and the patient's already in the OR, then no, you can't use that. Okay, this next one has to do with sequence 1030, pre-op beta blocker. How would I respond to a surgeon who states there are studies that do not support a pre-op beta blocker for isolated CAP? And I understand that there are some studies out there that is suggesting this, because I've gotten this question in my mailbox several times. And I've looked up the studies. However, at this current time, this is a NQF endorsed measure, which is part of the medication bundle in the STS composite quality rating for your star rating. So I think that's how I would respond at this point in time. It is part of the metric, and it is an expectation that the patient would have the pre-op beta blocker, or have documentation that it was contraindicated. Okay, another pre-op beta blocker question. In the past, we've always had to have a date and time documented to say yes to beta blocker. When did this change? So I think this has to do with the presentation in AQO. When we talked about some situations where you might not have a date and time, but you've got some other really clear documentation that the patient received that beta blocker within 24 hours. So it's not necessarily a change. We've always had to prove that the beta blocker was given within 24 hours of incision. So most often that would include a date and a time of the last beta blocker given. However, sometimes you don't have that, but you have other documentation in the record, such as the patient took the beta blocker this morning with a sip of water as he was instructed prior to coming to surgery. So you've got pretty clear documentation that patient took that beta blocker this morning. So in that instance, you can code the beta blocker, yes, was given, because even though you don't have a date and time, you have an other clear documentation that the patient did receive the medication. Okay, next question has to do with beta blocker. Yeah, beta blocker. Patient has a history of a right bundle branch block. Is this a contraindication to beta blocker therapy? And the answer is there's no automatic contraindications for medications. So you would have to have clear documentation that this patient had a reason for a contraindication for not taking the beta blocker. All right, now we're moving on to incidence. Sequence 1970. Is incidence just entry into the pericardial space? And the answer is it's not just entry into the pericardial space. It can include the pleural space, such as an open distal aortic arch or descending procedure. It may even involve the abdominal space if you're performing an open thoracoabdominal aortic procedure. I think that sometimes we changed this definition. I don't know, it's been a while now. At least I think it had started in 2.91, but to the incidence was defined by the number of times entry into a space. So there's some pretty good diagrams in the training manual showing you what spaces there are. There's, of course, the pericardial space, then you have your pleural space, and on the next slide, I like this next slide because it actually shows you the aorta and the parts of the aorta. Like you can see where the arch and the ascending are in the pericardial, like they're pericardial, and then it goes into the pleural space. And then as you get further down into the aorta, it goes into the abdominal space. So I think that's a great picture, and I'm a real visual person, so that helps me understand In the old days, incidents, we talked a lot about incidents as far as sternotomies, and that's not the case anymore. It has to, incidence is defined by the number of times in entry into a space. All right, so another question on incidents. Would it be a redo CV surgery if a valve-in-valve TAVR is performed 2 years after a TAVR? So the answer is no, because you had a previous TAVR, and a TAVR is coded as NA, not a CV surgery, for incidents. And now you're having another TAVR. And so basically you've got two NA, not CV surgeries. So the answer would be no. Incidence, another incidence question. If the patient had an open mitral hemiparotomy and then presents for an MVR, is that a first re-op? And that is a first re-op because the first procedure was open. It was a hemiparotomy, was into the pericardial space. And now he's coming in for an MVR. And that's also going to be in the pericardial space. So this would be a first re-op. Incidence again. If a patient had a prior open thoracic aneurysm repair and now is going in for a T-VAR, is the T-VAR the first re-op? And again, T-VAR is a catheter-based procedure. So you would be coding the T-VAR as not a CV surgery in this situation. All right, moving on to sequence 2131, aortic valve procedure. Do we, I think I did a typo wrong here. Do we need to enter a TAVR case that converted to a SAVR case while in the OR, into the STS adult registry, since this case would be entered into the TVT registry? Okay, so let's talk about this a little bit. So first of all, TAVRs are optional to enter into the STS because they have their own database, the TVT registry. If sites choose to enter the TAVRs into the STS registry, and this situation happens, so they're in a TAVR and then they have to convert to a SAVR, then the SAVR, which is a required case to be entered into the STS registry, is the index procedure. And the TAVR is treated as a prior CV intervention. So if this happens and you're a hospital that normally enters your TAVRs in to the STS, in that particular situation, the TAVR would not be the index procedure. The SAVR would be the index procedure. And last year at AQO, Dr. Whitman and I did a presentation on this, and I'm happy to provide, I send these slides out all the time to people, so to help them when this situation happens. It's got a lot of good information in it. So you can just send me if you don't have the slides, you didn't download them, you need them, send it into the mailbox and I'll pass it on to you. I'm sure you'll find them helpful. Okay, so sequence 2140, other cardiac procedure. I just completed an AVR with reconstruction of the annulus with a patch due to endocarditis. Is this coded as an AVR with other cardiac procedure? So as you heard at AQO, in the October training manual, we put an update in for endocarditis patients. So first of all, it's got to be an endocarditis patient. And the update states that if you're doing an AVR or an MVR, which requires the use of a patch reconstruction of any part of the annulus, that this is going to increase the inherent risk of this procedure. So you can code sequence 4135, other cardiac procedure. Again, this is just for endocarditis patients. And this started in October. So we're not going to go back and retroactively change coding on these particular patients. We're just going forward. This is how you can code these patients if they have an annular reconstruction.
And only endocarditis patients, right, Melinda?
Yes, only endocarditis patients.
Yeah, because the patch reconstruction or the patch can be used for other aortic and mitral valve cases not related to endocarditis, and the surgeons don't believe that that increases the risk of the procedure as
Right.
much as it does for endocarditis. That's why.
That's correct.
Okay.
We had a lot of conversations with the surgeons prior to making this change, and it's very clear it's just for endocarditis patients. And I think probably because of the mess that you get into when you get in there, as I'm sure all of you remember Dr. Horvath and his lasagna story. So, and if you didn't hear his lasagna stories at AQO, then I would encourage you to. Are those on the website now, Carol?
They're in the Learning Center for those who registered for AQO, and I'll show everybody where to go to find those after we're done here. Mm-hmm.
All right. So sequence 2195, CPT codes. How relevant are the CPT codes in the data analysis? We currently do not include them. So CPT codes are optional to enter and are not, we don't analyze CPT codes. Sites can choose to enter those codes if they find it helpful for their internal tracking purposes. Okay, sequence 2123, aorta procedure. If CTS involvement is only the initial incision in a T-bar, do we still include the procedure in the adult cardiac surgery database? Okay, so I've had this question come across the mailbox before. And the first thing is, if there's an op note done by the CT surgeon, then yes, you need to put it in. Because there's evidence that he was actively participating in the operation if he does an op note. And so we, of course, do include all T-bars if a CT surgeon participates in that T-bar. If it's just the vascular surgeon doing a T-bar, he's not on the participant agreement, then that doesn't go into our database. But if it's a vascular surgeon and a CT surgeon on your participant agreement, the CT surgeon writes an op note for that procedure, then it needs to go into the database. And isolated EVARs or abdominal endovascular procedures are not included. Okay, this one is sequence 6749. Is there evidence that the patient had a deep sternal wound infection within 90 days of the procedure? So the question is, now that SSI within 90 days is an optional question, do you see this being an analyzed metric in the future towards ratings? And currently then, and I don't think there ever will be, there's no plans to have this as a metric. This field was added for sites who want to align with the CDC definition of the deep sternal wound infection time frame. And okay, sequence 7003, transfer to another acute care hospital. When a patient is transferred to another acute care hospital, how are we supposed to get information from the hospital the patient was transferred that is not in our healthcare system? And I get this question a lot too. It's easy when they're in your own system. You can just go in and look at the records. But I find that if if the hospital's not in your system, I think the easiest way to do it is get your medical records department to do it for you. Go down to the medical records department, fill out the form, have them contact the other hospital's medical records department and to have the records sent over. It's just kind of a cleaner process, and it's a more formal process. And that's my first suggestion, is to try to go through medical records. All right, sequence 7011, extended care, transitional care, unit rehab type. Is LTAC considered short-term or long-term rehab? And it's considered long-term rehab. And it is rehab. That's the other thing. It might be acute rehab. It's definitely not an acute care hospital. Okay, so it's a long-term rehab facility. Okay, the next one is operative mortality. Sequence 7124. So we have a discharge to hospice, but we're still alive 30 days post-discharge. Is this an operative mortality? And yes, it is an operative mortality, because the definition for operative mortality includes all patients discharged to hospice, and that includes inpatient, outpatient, and home hospice. And we have another question about mortality and hospice. Patients may have DC to hospice or palliative care and not expire. If occurs, can we submit evidence for the STS for review? And the answer to that is yes. So what we asked people to do is to reach out to us and provide information about the patient being discharged from hospice for review. And then the case is reviewed, and an answer will be sent to the site. We've had a couple of those already that we reviewed, and the patients were actually discharged from hospice, and the site was able to code them as not an operative mortality. So yes, we're open to reviewing those cases if that happens.
Absolutely.
Okay.
You have two more questions. I think you will just have two more questions, Melinda.
Oh, good. All right, so STS audit, we had a couple questions about this. During audits, is the surgeon's note the primary proof of risk factor documentation, even if other providers have different documentation? So I think the training manual definition and intent clarification statement, in my mind, is the main guide for the auditor, because in the training manual, especially the risk factor section, which we're talking about in this question, there's really no direction that says we're to prioritize surgeon documentation over the documentation of other providers. What we are supposed to do is look at the timeframes and the intent and the clarification sections. I think that, and I tell people a lot when they send questions in like this, if you have conflicts in the documentation, and I know that happens all the time, then it's best to reach out to a provider to clarify that point. Because if it seems like conflicting documentation to you, then if the auditor looks at it, it's going to be conflicting to them too. So clarification needs to be obtained in those situations. All right, here's another audit question. Can the STS data collection forms that are filled out by surgeon and anesthesiologist be put in the EMR so it can be assessed if audited? And the answer is yes. But it's important that you follow your hospital's medical record policy to add documents to your medical record. And it would also be important that those documents be signed by the provider. That my last one?
That's it.
Okay.
And then I just wanted to go over, good job, Melinda. Thank you very much. And we have a couple questions. I just want to go over this one quick time before the 3-year cabbage composite, which will come out with Harvest 3, before we go over to questions, if that's okay with you. Melinda?
Oh, yeah, I'm sorry. Yes.
Okay. So I just wanted, we presented this on our last webinar. I just wanted to review it again. Starting with Harvest 3, which will be the report that is next released on the IQVIA platform, the cabbage composite and its components are changing from 12 months to a rolling 36 months. Harvest 3 dates are going to, and this is for the cabbage composite, so it's going to match the other valve and valving cabbage composites that we currently use, the 36 months. For Harvest 3, we'll look at dates from July 1st, 2018 through June 30th, 2020. Confidence intervals are changing from 98 to 95%. The number of required cases is 50 isolated cabbages in the 36-month time frame. It's okay if you join the registry after 2018. As long as you meet the 50 isolated cabbage cases in the 3 months, you'll still be included and get results back. Mortality threshold stays the same at 2% or less. And we're going to look at that on rolling 12-month periods. So we're going to look from July 1st, 2018 through June 30th, 2019, that you have to have 2% or less of missing and unknown. July 1st, 2019 through June 30th, 2020, and July 1st, 2020 through June 30th, 2021. Each of these 3 periods needs to have that 2% or less missing or unknown to be included. In addition, we also look at the NQF measure, the NQF variables, which are beta blockers, discharge antiplatelet meds, discharge beta blockers, discharge lipid lowering medication, and IMA usage. We look at that for 5% or less on these fields to be included, and it's the same idea with the rolling 12 months. So we would look at each of these 3 periods separately to make sure you were 5% or less, and then you would be included in the model. And then I get quite a few questions, so I cleaned this slide up a little bit, and I tried to clean it up, the new report overview with the information on this 36-month cabbage composite is being finalized, and I should have it posted hopefully by Friday to the IQVIA library. But just to clarify the case volumes, so the isolated cabbage is 50 for the 3-year time frame, their 36-month time frame. For AVR and AVR cabbage, it's 10. For MVRR, it's 36. And for MVRR and cabbage, it's 25. So this will all be clear in the report overview. And I hope that's helpful. And we'll get to questions on this as soon as we finish with the other ones. So that's all I had, and we can go. If you have questions, you can email me at ccrone@sts.org. Operational questions, stsdb@sts.org. And you all, to get a hold of Melinda, it's the FAQ question. And before we go over to questions, though, I just wanted to show where to access the AQO information. So hold on. Let me pull this tab over here. Under online learning and the STS Learning Center. If you click on this, I think you just have to click it again. Let's see what happens. So it'll take you to this welcome portal. You would just log in with your login credentials, the same credentials you use to access AQO. And this takes you into the Learning Center. This is where all of the AQO content has been, is being stored. And on the right-hand side, the reason it's coming up here is because I already started looking at this. But if you wanted to find it, you can go to the catalog. And I think I just typed in AQO. Let's see if that works. Nope. Hey, Emily, any idea how we search it? I may have just scrolled down to find it before.
You know, I think that what'll happen is, since if all of the attendees, since they're enrolled, it'll always pop up on that side. At least that's what it was like when I logged in.
Okay.
Maybe type in 2021.
Yeah, I don't see it there.
It
Okay.
might not be in there, Carol, because it's not like a product, because we're not selling it.
Oh, I see. Okay, so maybe it's just assigned to everybody. Well, if anybody has any problems accessing it and it's not listed over under in progress, just reach out to Emily or myself and we'll be happy to help you find it in the Learning Center. But it's here, and then when you launch it, you'll see on the left-hand side here is kind of the bookmarks for everything. If you don't see that, it's because this arrow was all the way to the pointing to the right. When you click on that, the bookmarks will open, and then you'll see it broken down by track. So for adult cardiac, I click on the caret, and then it'll show you all of the sessions that happened, including the on-demand sessions. Under resources is where you'll find the handouts that went along with each of the presentations. So that should be very helpful. And then there's also the access to the e-posters here as well. So hopefully that's helpful. And then just as a reminder, if you wanted to submit clinical question to Melinda under registries, STS National Database, and you scroll down just a little bit, you'll see the clinical questions request form, ask a question. So that's all the demonstration I have, and we can go over to questions now. Ready? This one I think is for IQVIA. This says, hi IQVIA, this may not be related to our topic for today, but when running data download reports, how can we add the comments to the form to the report? Thank you. IQVIA?
Sorry, I was on mute, double muted myself.
That's okay.
So how can we add comments added to the form? Is it a field on the form? Because there's an option when you're running the report to select all variables. So is it a specific variable where you're capturing that? Those comments? Because if you choose that option, it would pull all variables, and that's the only thing I can think of. If anything, Christine, if you can give a call or send an email to our support team if you needed to give further context, but I think you should have the option to select all variables, and then it would just pull whichever variable you're putting that comment in, it would pull onto the report.
Okay. And yeah, maybe she could reach out and ask if she has questions on that. Thank you, Melanie.
You're welcome.
And then Christine says that knowing the 5-meter walk test triples the risk of any procedure made by the she made her facility start doing the 5-meter walk test because it does triple the risk of any procedure. So she hopes that other facilities do that too. And STS has been trying for many years to get sites engaged enough to perform that 5-meter walk because of the impact on the frailty measure for those patients. So it would be great if more folks could start doing that as well. Thanks, Christine, for the comment. Next question is, our comment is, I'm new to the registry STS world. My question is, if I need to recorrect from my last harvest, How long do I have to be able to fix it? Will it show in the next star rating from that correction? So if you're making updates and you want them included in your next harvest, which is harvest 4, that closes on December 17th, you need to get those updates into the IQVIA data warehouse prior to that December 17th close date. So it will be shown on your next report, and then also shown on your next star rating, which would be harvest 1 of 2022. Audrey's asking, when can we see the multi-procedural composite, the failure to rescue the multi-valve composite, and the proximal aortic surgery risk model? So all of those are in some level of development, and they're not yet ready to be released, but STS will communicate out to sites when those new measures or new composites or new analytic capabilities are in place. We don't have a date at this time. Melinda, this one's for you. This is from Kathy. It says, can MD document contraindicated for sequence 1030 if he or she doesn't think it is important in the patient's best interest, i.e. contraindicated due to study per yada yada at all?
Well, the contraindication has to be for a medical reason. So if the physician thinks medically that this patient should not have a beta blocker and documents that, then that would be appropriate.
If a patient had an impella placed, then went to the OR for a cabbage, what would be the incidence of operation for the cabbage?
First CV surgery.
Yeah, assuming they didn't have a previous CV surgery.
Yeah, and assuming it's just a catheter based assist device. That's what I'm assuming it is. Peter, I don't know.
Yeah, impella doesn't change usually doesn't change the incidence. How can a PRN inhaler be considered chronic use of an inhaler?
Well, most people who have chronic lung disease use their inhalers PRN. They may have an inhaler that they take once a day or twice a day, or they may have 2 or 3 inhalers, and one of them's PRN and they take it 4 or 5 times a day. So it's aimed to treat their lung disease, their chronic lung disease. They use it on a regular basis. It can be counted towards the criteria.
Okay. Regarding sequence 405, patient has a low FEV1. The RT, respiratory therapist, will document some of the following issues. Patient unable to sit up due to IABP. Patient does not understand instructions. Patient with poor effort. Patient unable to complete due to coughing. How do we document the FEV1 in those instances, Melinda?
Well, again, if there's documentation that this isn't a valid test, which some of these examples make me think that it may not be a valid test, then I wouldn't use it if you've got clear documentation that it's an invalid test.
Yeah. Okay. Victoria is asking if they need to include standalone BADs into the registry.
No, they're optional.
They're optional. The FDA approved long-term ventricular assist devices should be going into the Intermax registry, but for purposes of the adult cardiac registry, the standalone ventricular assist device do not need to be entered in. If a cardiac, those are standalone, just to clarify, if a cardiac patient returns, okay. Patient returning a year after for sternal wire removal, is this case reportable?
I wouldn't put that
I
in.
wouldn't either, yeah.
It's like I get questions sometimes about the same thing for wound infections, and they're coming back, for an infection or something, and that's not a reportable case either. It's not like they're really operating on the heart. They're just cleaning up the infection.
Right. Next question. In the past, Donna had told us that TVARs did not need to be entered into the STS if the site was already entering them into the SVS registry. Has this changed?
Well, I'm assuming this changed when we got that huge aortic module that we fill out now. So I don't know how long ago Donna told you that, Cindy, but ever since we started when did we start the aorta modules? 2.81, Carol, or something like that?
2.9, July 1st, 2017.
Yeah, then we wanted the TVARs to go into the adult cardiac registry.
Yeah. Would STS consider changing submission of cases from date of procedure to discharge date? It would be easier if you submit to multiple registries that you submit by discharge date. No, we look at procedure date because that's how we determine all the outcomes and everything. So we use the OR date. I think it's a good question. And if I can get more of an answer as to the reason why we need to use the OR date, I'll provide it in an upcoming webinar. Increase confidence interval to 98 rather than 95. So we were at 98, but we've moved it to 95. Oh, you want me to say decrease? Maybe it should say decrease. Okay. If a patient moved and is lost to 30-day follow-up, is this patient removed from the denominator for 30-day mortality and 30-day deep sternal wound infection? Melinda, would you like to take that one?
Yeah, they're not removed. They're going to show up as missing. And that's not good for star ratings. So it's very important, Tabitha, to try to track this patient down. The surgeon should have some information as to what happened to this patient that he operated on.
Great.
Because if you leave this blank, or if you code this unknown, that's still going to show up as missing in the thresholds for mortality.
Thank you. Lisa's asking to show the slide with the composite rating minimum volume requirements again. So for cabbage, it will be 50 isolated cabbages in 36 months. And then for AVR cabbage, it's 10. For MVRR, it's 36. And for MVRR plus cabbage, it's 25. Next question, please. Emily, this one is for you. Where can they find the CEU forms?
Okay, so I just put the link to Core Excel's evaluation form in the chat. You have until, I believe it's January 15th to fill that out. What happens is we're going to do it on a rolling basis. So it for 3 months. So yeah, I put it in the chat.
Great, thank you. And then another question for you, Emily.
Okay.
It says Julia did not sign up for AQO. What's the requirement for her to access this information?
Yeah, unfortunately, registration is closed for AQO. We're not offering it as a product to purchase since AQO was free this year. I would maybe suggest if you have someone that you're like the hospital that maybe attended, maybe getting in touch with them and maybe they can share some of the presentation slides, but unfortunately we just cannot sign anyone up at this time.
Thank you. And did you want to take this one from Heidi as well about offering virtual AQO in the future?
Sounds like a lot of programs at STS are being evaluated for possibly hybrid. I don't think that we have a clear answer on that right now, but all options are being discussed.
Great, thank you. Next question I could take. If we choose to, will we still be able to submit data for the upcoming submission by November 12th? Or was the deadline extended because IQVIA will be down? So you could certainly submit your data and clean up and be ready to go for harvest close at any time. You could do it today and finish up your submission for harvest 4, knowing that all your data is set and ready to go. The deadline was extended because we're in hopes that we can get the harvest 3 report back to sites prior to closing the next harvest. And it looks like we should be able to. We're just waiting. IQVIA just received that data from DCRI, so they're ingesting it and verifying their programming, working on their programming for the changes in the cabbage composite. So yeah, you can certainly, it's not related to an IQVIA issue. We extended it for that specific reason. And you certainly can submit your harvest for harvest 4 and make sure it's all cleaned up. Since we have an open submission, you could certainly do that. Valerie tried to submit a question, but got an error message that the FAQ platform is not working. So I think you've been getting questions. I saw another question come over earlier this week that somebody else had an issue with it, and it was internal at their site. They were blocking the STS website for some reason. So Melinda, have you heard of anybody else having issues today?
No, I got like 30 questions in there. So.
Yeah, I think it should be working, Valerie. Feel free to reach out to me, and I can put you in contact with our IT help desk. But usually what I've seen is it's usually been an internal issue, and you probably need to work with your IT, but happy to help. Tabitha is asking, does documenting the 5-meter walk fall into risk adjusted rates? It is not in the risk model. And the reason it's not in the risk model is because we don't have enough data to add it into the risk model, even though we know that the frailty indicators are very accurate in predicting outcomes. And people with poor 5-meter walk tests have a much higher likelihood of having complications post-operatively. We just don't have the data because sites haven't been submitting it to us.
Yeah, and if we did have the data, then the goal was to have that in the risk model. We just, not enough sites do it.
Right. So Pam, you said your FAQ submission was not internal, is still not working. So you can email it to me at ccron@sts.org. I'm not sure, we're not having issues with the platform, so you may be blocking STS from accepting that. But happy, if you want to reach out to me, I could ask our IT team to help you with it. And send me your question so I can send it over to Melinda. PRN inhaler is not chronic use. I don't understand how this can be coded as chronic lung disease. So chronic use just means, I think what you're saying about this PRN inhaler is not regular use, but you can certainly have a PRN inhaler that the patient has been on chronically or long-term, right? It's not an acute thing that they're using just for an occasional bronchitis. It's something that they could be using every day. And then she's saying, I don't understand how this can be coded as chronic lung disease. Did you want to clarify on that, Melinda?
Well, no, I think you just stated it quite well. I mean, it's just because it's ordered PRN doesn't mean that the patient hasn't been on it for years, that they don't use it every day on a routine basis because they have lung disease that requires that. So I think it's just semantics. I think, in my mind, if it's ordered, because most often for lung issues, it is ordered PRN, most often. And the patients who are on it chronically for years, sometimes they take it 2 times a day, sometimes they take it 4 times a day. It just depends, but they're taking it on a regular routine basis.
Sure. And then there's 2 other questions. Somebody else is asking if it includes asthma patients. And then Beth is stating that her daughter with asthma has a PRN inhaler. So I think there's, additional questions here that if you want.
Asthma can be added. We did add asthma into the chronic lung disease definition in 4.2 if they meet the criteria. for the severity. Because asthma can, over time, progress to a chronic lung disease.
That's right. Okay, thank you. And do you have just a few more minutes, Melinda, to stay on and answer these last couple questions with me?
Mhm.
Okay, can you please repeat what you said about the 50 isolated cabbage requirement? So 50 is the number of isolated cabbages that a site needs to have over the 36-month time frame to be included in the composite analysis. Julia says, I am still having issues encoding in a number of the EF. How many times this data is descriptive, for example, globally improved, and another is preserved? I think that our
Yeah.
recommend to reach out to whoever is reading those echoes and try to get something a little bit more objective, right, Melinda?
Well, yeah, we have the, in the training manual, we do have some descriptive terms that can be used. Unfortunately, globally improved and preserved are not on that list. So hopefully you can reach out and have them use the terms that's on the list, or even better, maybe they can give you a number.
Okay.
It is a frustrating thing when that happens.
Yeah. And the next question is, patient was discharged on lipid lowering, other at discharge, but not on lipid lowering statin, not contraindicated. Does this align with the NQF requirements?
No, it has to be a statin.
Yeah, and I'll show you to find the information on the NQF requirements under registries, STS National Database, adult cardiac, and then data collection resources, version 4.2. If you scroll down here, you'll see the NQF endorsed measures. And this is going to tell you, if we're looking at the lipid medications, this will tell you what is and what is not included or excluded. So they need to be lipid lowering. Statin is the field that we look at for these. So does not include those other categories. Okay. If a patient is on chronic use of an inhaler, but you have no other documentation for chronic lung disease, can you still code chronic lung disease? She's talking about chronic use of an inhaler.
Yeah. Well, the thing is, the first part of the definition for 405 talks about the patient has a chronic lung disease. Okay. So you have to have some documentation that there is lung disease present. And in this situation, if you see this and the patient's been taking an inhaler for a very long time, but you don't see any documentation of lung disease, then I would clarify with the provider, because that's kind of the first step. Do you have chronic lung disease? And if you do, what's the severity?
Yeah, this is a hard one. Well, we always have a lot of questions on chronic lung disease and NYHA for some reason. Okay, if the patient is seen on day 29 and shows no further contact, would you consider this as a 30-day visit if no noted readmission?
Oh,
You want to take that one, Melinda?
well, technically, 30 days is the cutoff. So at day 29 and never seen or heard from again, he could have died. We don't know. You don't know is what I'm getting at. So you really need to make sure that it's at the 30-day or after 30 days so that you know that this patient was alive.
That's right. To be clear, data ending September 2021 cases are due on November 17th. That's right. It's OR dates through September 30th, 2021, which is the due date of harvest closes on December 17th. You can continue submitting cases even after the September 30th date. They just won't be included in that next analysis, but it's totally fine to keep submitting your cases and getting them in and preparing for the future. It's totally fine. Jennifer's asking, how far back do we need to be looking for positive COVID test? So we started collecting those fields in April. I think April 1st is when we collected those, and I would just go back as far as you can to try to find that. If you're doing a patient now and they had a positive COVID test in April of 2020, right now that patient will be excluded from analysis. But STS surgeon leadership is still looking at adding in a time frame for those exclusions. But I guess any positive COVID test, and we are not saying to only go back 6 months or anything like that at this time. Looking at Christina Mendoza's comment, it suggests that the 5-meter walk test triples the risk of any procedure. I think you just commented that it was not yet in the risk model. Can you comment and clarify? Sure, Chris. So it's not in the risk model, but we would really like for it to be in the risk model. We just don't have enough sites collecting enough of this variable, the 5-meter walk test. We don't have enough sites submitting data to us on that. So unfortunately, even though we know that it's a great indicator of frailty, and we know that patients with poor 5-meter walk tests do have tripled the risk of any of the procedures, we can't include it in the risk model. And that's really unfortunate for sites, especially because we don't have any other frailty indicators right now in the STS. So it's very, it's really sad that we can't, I don't know if the sad is the right word, but it would be really helpful if we were able to get enough data and sites started collecting that point so we could add it into future risk models. So you get that, kind of get that credit for those patients who are very frail and have a poor outcome afterwards. It kind of offsets it with your observed to expected outcome. So yeah, unfortunately, we just don't have enough data at this time to add it in. Should we resubmit data for 2018 and 2019 where we identified discrepancies to improve our outcomes for the 36-month composite? And I would say yes. If I found, since the cabbage composite went to 36 months, I would definitely go back and review if there's any place for me to improve those outcomes, or make sure my data collection was as accurate as possible for those 3-year timeframes. If a patient is given heparin in the cath lab prior to surgery and discontinued same day, should we mark pre-op anticoagulant, yes or no? Melinda, do you want to take that one?
Well, we don't collect one-time doses of medication, so
Okay.
I'm not sure if that's I don't know. If it was just given in that cath lab, I'm assuming it's probably just a one-time dose, so we wouldn't capture it.
Should PRN inhalers be keyed under the risk factor inhaler use?
Is that, I'm trying to see what sequence that is.
Oh, and I don't know.
I'm looking.
And Julia, I'm sorry, I see your question is next. It says in the ORTEE, and I'm sorry, I don't remember what your previous question was to add that on.
Oh, I remember what it was. It had to do with the EF and the documentation of preserved and things like that. So.
Oh yeah, that's hard. And the surgeon documents EF preserved or function.
Yeah. Well,
preserved.
or the anesthesia. You just need to educate them. That's what you need to do. This word doesn't work. Or if the only other thing you can do is you can develop a protocol for the surgeon to sign off on. So when he says preserved, it means 55 or it means 60. And you can have that as a protocol in the event of an audit. So that's the only other thing you could do in a situation like that.
That's great. Thanks.
So the question now is about PR. This is the risk. So they're talking about sequence 455, inhaled broncho medication. This is capture patients with prescribed home bronchodilator therapy prior to admission. Capture routine use. Asthma patients can be included. I think again, if they're on it at home, it's routinely used. What do you think, Carol?
Yeah, I mean, That we could always ask the surgeons to clarify on this a little bit further for us. I know that what the issue is that you might have somebody who has, like I have inhalers prescribed, but I don't use them except if it, I get a upper respiratory that turns into a lower respiratory, and then I use it maybe once or twice a year for PRN for a couple weeks or something, but I'm not using it all the time. Or even the same with like, different asthmas that are induced, environmentally induced, those types of things where you have those inhalers prescribed, they're PRNs, but you're not really using them unless it's a couple weeks of the year or whatever it may be. So maybe we can just ask the surgeons. It's really hard because it's going to be difficult for the data manager to figure out how often somebody is using an inhaler, right? So I think the surgeons tried their best to come up with this intent clarification, but we can always bring it back to them and see if there's something more. What do you think?
Yeah, it is a difficult one. I mean,
Yeah.
And so I know in the past, historically, if it's been PRN and it's been chronically used, we've said yes, because that quite often that's the way it's prescribed. And sometimes on the med reconciliation, you can see a notation of the last time the patient used it, or the frequency, or sometimes you'll find it in a note that may be from pulmonology or somebody talks about how often the patient uses it. But
Yeah, let's finish up.
we can ask them, but it's kind of I don't know.
Yeah, it's a tricky one, and I'm not sure
Tricky
that
one.
any clarification we provide is really going to be helpful, right?
Yeah, I mean, I think, I'm just clinical judgment, critical thinking about the situation.
Yeah, we changed that PRN. Susan just put in the comment that we were told not to use the PRNs, but we changed that. And there was a reason we changed that is because those patients still have lung damage who require inhaled bronchodilators. They still have some type of lung damage from all of the times that their lungs are constricting and things like that, or the bronchioles or whatever are constricting. So there's that was the reason I think why we changed it to include the PRNs.
Yeah, and so I mean, maybe we can, I don't know, we can ask them if I don't know how to make it any.
Yeah,
If
I think
anybody
this,
has any
you can end
suggestions
up
of how
making
we
this
can
a
make
worse
it
problem.
clearer.
I like this. It just says if PRN inhaler with a diagnosis of lung disease, just count it and move on. And
Well,
yeah.
that's kind of what I think too,
Yeah.
me personally, but because it's very difficult to quantify how often it's used.
Yeah, I agree with that. So I think, okay, I'm going to go to the next question. Should we include a patient that had a closure of mediasternotomy separation without debridement?
As an index procedure, no.
Okay,
Not if they're just coming in for that. That's not an index procedure.
great. And then Lauren's asking since the Harvest 4 was given an extension, what's the deadline for Harvest 1? The dates have been posted on the website. It's 8 weeks from the last date in the reporting period. It will be February 25th. Has any thought been given to using the frailty score like the ones used in NCDR, CAth, PCI, for a frailty metric? So actually our quality metrics task force has come up with a frailty metric that they are in some stage of finishing up, and it will be implemented into the database. I don't have a date as to when that will be. And there is Suzanne, if you were able to join AQO, there's a presentation on that from Dr. David Shahian in the adult cardiac section. We are a new facility and only have 32 isolated cabbages. I know we won't get a star rating, but will we get an official harvest report with comparable data? And I believe you will still get your benchmark data. You just won't get a star rating or any of the composite pieces that go with that. You should still get some of the other data back. With the other, will the other accepted STS reason for no internal memory be corrected and included out in the IQVIA composite? So that was actually updated with Harvest 2 report, so it should have been included in that report. I have to take a phone call real quick. Hold on. Melinda, do you want to take the next questions?
Yes. So will the other accepted STS reason for no IMA be corrected and included in the next due out acute composite? I don't know exactly what Sue's asking about here. So I'm going to wait for Carol to get back because I don't know the answer to that question. So I'm not sure what you're talking
Sorry
about.
about that. Okay. Well, the other, so I did the internal memory one. We did that.
Oh, you did?
Right.
Okay.
Yeah, it was implemented in Harvest 2, so those updates should have been seen, and it will be, you'll see it for sure in Harvest 3. I confirmed that with DCRI earlier this week.
Okay, so this question, patient has a tumor. It's going
Oh
back
yeah,
and
right
forth.
atrial myxoma excised, tumor is slender stalk and was following back and forth through the tricuspid valve. So tricuspid valve impossible to completely evaluate. TR bad enough to require repair. Surgeon said TV repair was not unexpected. Do I count this as unplanned due to unsuspected disease or anatomy?
Well, it would definitely be unsuspected disease. It wouldn't be a surgical complication, I don't think. I mean,
Yeah, you could code it as either one, I think, right? As planned or as unplanned due
Yeah.
to unsuspected disease or anatomy. I think what would be the thing that would make me choose one of over the other is what was on the consent when the patient went to surgery.
yeah, that's what I was going to say. Was it
Yeah.
on the consent?
If it wasn't on the consent, then you're going to code unplanned due to unsuspected disease or anatomy. If it was on the consent, then you're going to code it as planned.
Mm-hmm.
Okay. In cases that I see, if a patient has a PRN inhaler and uses it more than PRN, usually they also have a steroidal inhaler as well. Yeah, I agree with that. You usually see that combination. And then Michelle's saying, when is our third quarter data due? So third quarter is data through September. OR dates through September 30th of 2021, and that's due on December 17th. And the Harvest page has been updated with that information on sts.org, STS National Database, and then Harvest schedule information. 2021 is first. This is Harvest 4 is quarter 3 data. OR dates through 9/30/2021, and it closes on December 17th. And then the Harvest for next year are posted. All right, I think we're going to end here. I have an electrician coming. So I accidentally unmuted myself. So sorry about that. So thanks, Melinda, for all of your help today and for presenting such wonderful thought out questions and answers. And thank you everybody else for joining. I hope you have a great rest of the day. And I hope this was helpful for you. And
Great
see you in a
Carol.
couple weeks.
All right.
Bye, y'all.
everybody.
Good job, Melinda.
Thanks.
Bye.